I can hear it. Yeah. I just need to make sure I'm on mute. Yeah, all good.
You often have to teach them how to do it.
Can I get you guys on Teams to just mute your mics, please? Before somebody says something, they regret, oh shit, I was on Teams. Out loud. Thank you guys for doing. Your 3 seats are still available at the front. Oh, no. Nobody's stolen them, funnily enough. Guys, there's a couple of chairs over there if you want. Come on in. No, that's Okay, thank you everybody and welcome, and thank you to the team and everybody else who helped us to make this area a little bit more COVID safe. Thanks for taking the time to come to the forum today. Can I start by just acknowledging the Noongar people as the traditional owners and custodians of the land on which we work, and pay my respects to elders past, present and emerging. North Metropolitan Health Service recognises, respects and values Aboriginal cultures as we walk a new path together. The aim of today's session is to provide you guys with an update around our COVID readiness for when the borders open on Feb 5th. Thank you to you who have sent through the list of questions. So we've had a range of questions from clinical staff and non-clinical staff on the floor. And, a substantial amount of work was already done in 2020 around the Delta strain. And while some of that work is still relevant, we're getting ever-changing information from, and so we're having to change our approaches, and we're having to be agile in our response. Today, we have the pandemic team response group, and I'll get Ajitha Nair, who's the lead, to introduce the team and to provide you with some more information. So the idea is just to work through the information at the moment and then give you an opportunity to ask some questions. It's our intent to have 2 weekly forums going forward, and we'll continue to take some questions from you via Ask Janik email. So if you have questions after this, we will be recording this session. So if things come up today that we can provide answers to, we will do our best to do that. And I might hand over to Ajitha. Oh, that was my bit. That's your bit.
Thank you. Afternoon, everyone. Thank you all for coming. And I'm just going to pull my mask down for a bit and stand far away from you, just because it might be a little easier for people on Teams to hear me. I must start by apologizing because I've only come back after 2 weeks of leave today, and I did try desperately to get through my 500 emails this morning because I made it a point to not check emails when I was away. So if there's something that's really current, up to date, and latest, I might have to come back to you with some additional information. And that sort of nicely segues into what's happening in the COVID world. As you all know, with the Omicron situation, things are changing very rapidly. We are in touch with our colleagues in the eastern states and overseas on what they have been seeing as they surge with Omicron, because clearly it's very different to Delta in terms of transmissibility, severity of symptoms, and what they are experiencing in hospitals in the eastern states. I'm probably also going to start by introducing the team, and you probably all know Linda Cruikshank by now, and Naman Nguyen, who have been working with me very closely over the last several months, reviewing, revising, and updating our plans that we put in place in early 2020. Pandemic started. Fraser Brims, who's our medical lead, is missing today. Hopefully, Fraser will be able to join us shortly. Oh, great. Sorry, Fraser. Welcome. Do jump in and correct me if I am saying something that is outdated or wrong. Probably going to give you a bit of an overview of where we are at in terms of planning and what has been happening over the last few months in terms of for the arrival of COVID into WA once the borders open on the 5th of February 2022. The question that probably have been asked 500 times in the last few weeks is, do I know if the borders are actually opening on the 5th of February? Unfortunately, I don't have an answer to that. It's probably just the Premier who has an answer to what is going to, whether it's going to open on the 5th of February at this point in time. The information that we have is that the borders are still going to open on the 5th, which will mean that we'll start seeing cases of COVID in the community sometime shortly after that. All of our planning, preparedness, and readiness has been keeping that date in mind, of the date of the 5th of February. And what the WA Health Department put together in October last year was a 100-day readiness plan, 100 days before the 5th of February, on what is it that we need to do in the next 100 days to prepare our state for the arrival of COVID in the community. That was actually based on the modelling that was put together by the government and published. The document is available on the internet, but as you know, the modelling was based on Delta, which was the prevalent strain at that point in time. We aligned our North Metro plans and then the Charlie's plans very much in congruence with the state plan. And some of the things that I'm going to talk about is the work that we have been doing under the auspices of that plan, just to make sure that we are in alignment with the state and the other hospitals in the state. So what's changed in the last few weeks is Omicron. Before I went on leave, Omicron had just arrived, and the eastern states and the United Kingdom and South Africa were beginning to see that surge of Omicron cases. And at that point in time, it was a bit of a wait and watch on what happens over the next few weeks and how many people are put into hospitals and how many people have to required ICU care because of Omicron. What has become apparent, particularly in the last week or 10 days, is the volume of cases and the number of people who are in hospitals. Based on the information that we have from the eastern states, most of the patients in ICU are still Delta, particularly in New South Wales and Victoria, and they are unvaccinated. There are no Omicron cases in hospitals or ICU, but a proportion of them, and a significant proportion of them, still have the Delta strain of the virus. Obviously, the other thing that has really apparent is the volume of cases, which puts the number of people into hospitals and the strain that places on the health system, whether that is over east or that is potentially likely to happen here when we have a surge. So clearly we have to adapt and change our plans based on our colleagues' experience, both overseas and interstate, and make sure that our plans are flexible and are able to be changed at short notice to be able to support the care of our patients when we have COVID in the community. Just going to we may probably have gone through this last year when we started the pandemic. Just our governance structure hasn't changed much. What we have done over the last few months, particularly thanks to Linda and Nam, and is put some structure around it and worked really hard to get some guidelines, protocols, education, training, etc. in place before the 5th of February. We've got the pandemic response group, that is your overarching planning committee, and underneath it sits the clinical reference group that develops guidelines, the patient flow working group, a working group looking at infrastructure, technology, equipment, things that are needed to safely care for our patients when we have COVID in hospitals, and that included purchasing pulse oximeters, equipment like HEPA filters or air purifiers or air scrubbers, which we will be using start seeing cases in the community, plus many other things which will be useful when we have COVID in the hospital. Obviously, we haven't sat together in a room and made this all up. We've had input from key clinicians in the various departments, and we have lots of people working very closely with us to make sure that your voice is heard and the feedback from the wards, clinical areas are taken into account when policies, documents, guidelines, etc. are being developed. We've got the education, training, and simulation group, which Kimberly is leading, and we're really working with in the beginning with the high-risk areas, but also with the other clinical areas on some simulation, some training, some practice for what it will look like when we have COVID cases in the community. Workforce, and I'll come to communication in the end, but some of you might have read our COVID comes out regularly every Friday, and I know some people have commented that it's been very light on at the beginning when we started in November, but that was only because we were getting our documents, etc. together. As we go ahead, it will have more information on where additional information is available, where the documents are located, and where do you go for help. Policies and guidelines. Our intranet page has all of our current policies and guidelines. I think it's important to mention that most of these, if not all of these documents, are currently being reviewed and revised, and just to make sure that it aligns with the changes that are happening both at a state level, Commonwealth level. You might have read about rapid antigen testing, the whole debate discussion around who gets tested, the shortages in the eastern states. All of that work is happening at the Commonwealth level. So we are working on reviewing and aligning all of those policies with both state and Commonwealth guidelines and policies. Our COVID-19 policy, which is available on the intranet, is, as I said to someone this morning, our Bible. That has our most up-to-date and recent information on what do we do and how do we care for COVID-positive patients and what is it that we are required to know. This document gets updated regularly. It's version 7 that is currently on the intranet, but version 8 is not far away because we keep reviewing and revising the document based on updates from the state. What is also on the hub is clinical guidelines and supporting documentation, and this is what the teams worked on really hard over the last several weeks. Simple 1 to 2 page documents, most of them flow charts telling us what to do when we care for COVID patients, look after COVID patients. What's there on the slide is an example. So that's the oxygen escalation pathway, which is available on the hub, and many of these documents will start going up this week and will be from this week and will be helpful when we start seeing cases in the hospital. The bed escalation plan, lots of questions about the bed escalation plan. As you know, when COVID hit in 2020, what we had to compare at that point in time was what was happening in UK and Italy. We put our plans in place, assuming that we'll have a massive surge of COVID and COVID patients in the community. So we had a bed escalation plan, which again is available on the internet, which very broadly was based on patients being admitted to the respiratory ward and progressively being expanding into other fifth floor wards, followed by other areas of the hospital. I just want to reiterate that still remains our current plan until we review and revise the plan. So a new plan is currently in development, but if we have an outbreak in the community tomorrow, and if we start getting a surge, say the next week or the week after, that remains our plan. What has happened in the last few months essentially is the system working to create additional capacity to look after COVID patients, not just within this hospital, but in every hospital across the state. And what Charlie's Osborne Park has got commitment to or support and funding from the health department is on some additional beds. So there's a 30-bed modular ward that is currently in development at Osborne Park. So this is a custom-built ward that will be placed in Osborne Park and looks super cool when it's ready because it's customizable and can effectively function as a 30-bed ward. Ward. This will be ready by the end of April. The state has also purchased on our behalf an additional ward at Hollywood Hospital. Part of our pandemic plan is relocating G71 or G71 to Hollywood Private Hospital to then designate G71 as our first COVID ward. The second phase of this plan is to then progressively take over another ward on that floor. And at this point in time, G73 is the designated ward. Our cancer patients are located in G73, and the decision was made to actually not have a very vulnerable cohort of patients on the same level where we would be cohorting about 30 to 40 to 60, I don't know, whatever number of COVID patients that we would get when we had an outbreak. For that reason, there was a decision to swap ward J73 with G54, which is the respiratory ward. It also is very functionally effective from a support point of view because the respiratory ward has had the experience of seeing COVID patients last year. The transition of G71 to Hollywood is anticipated to be completed on the 17th of January, which is when G71 will be available to function as the COVID ward. That bed escalation plan is currently in draft and in development and will be uploaded on the hub as soon as it is finalized and endorsed by the pandemic group. The other addition to beds is commitment to 10 additional ICU beds, and there's been a proposal to the state, which I believe has gone up to the Treasury, and there is optimism that that will be supported to create some additional ICU capacity. We've also been allocated funding to refurbish C14 as a new 30-bedded ward to accommodate more patients on this side. So I think that's just a summary of the bed escalation plan. As I said, the revised bed escalation plan is in progress. And part of the reason why I don't have it today to tell you that it is ready is because it has changed from the time that we talked about it 2 weeks ago, because the plan was to actually accommodate patients on G71, move over to G73, and we did not expect, based on the modeling for Delta that was put forth in October, November last year, that we will have more than that many number of unwell respiratory COVID patients. It's very likely that we'll have COVID patients for the foreseeable future in the hospital. Someone with a broken leg can still have COVID until we have COVID in the community. Obviously, with Omicron, it's changed, and what's coming forth from the eastern states is realistically the one ward or the two ward or the floors that they had designated for COVID got filled really very quickly, and they then had to surge into other areas. So what the team's working on is actually that surge plan and what it looked like when we have that level of community transmission. It's been. I think we are in a fortunate position to have that hindsight experience from the eastern states, which gives us a little bit of time to plan and prepare as best as we can. PPE, I'll probably let Linda speak a bit to the PPE part of it. Based on the information that we have from the state, there are adequate supplies of PPE, and the state is constantly working with the suppliers to replenish the stocks, to purchase additional PPE when there is a surge and when there is increase in demand. So at this point in time, the information that we have that there are no supply issues, and we are regularly provided with the spreadsheet of the number of each of the PPE equipment in stock in the state.
Yeah.
Linda might want to add to the storage.
Yeah, so I guess that some of the questions is about storage and the environment to have large amounts of PPE available. Obviously, we don't, our wards don't have a great deal of storage, so we'll be talking about getting more regular, frequent deliveries of PPE so we can maintain the supply. We'll also maintain that really large PPE store in the basement that we'll be able to access for times after. But I think the most important, the key thing that everyone needs to do, anyone with a patient-facing role needs to take the opportunity now to get N95 fit tested and make sure that they know and understand what mask that they need to wear in the workplace. There's several thousand spots available with OSH fit testers over the next few weeks. They've got a goal to get everyone on site fit tested by the end of the month, but everyone needs to really take that opportunity and encourage all staff to do that.
Thanks, Linda. Lots of questions about what the workforce plans are and whether we would be quarantining staff who come in contact with someone who has COVID in the hospital or in the community. As you remember, when COVID started, we had only the PCR available as the test for COVID. Took 48 to 72 hours to come back initially. Obviously, that time frame has reduced a significant bit. We didn't have any vaccines available at that point in time. We have evolved. We now have vaccines. We have good PPE, and we have fit testing, and we have tests like rapid antigen tests, etc., that are available. Again, based on the experience from the eastern states and guidelines that have been published by the CDNA, the plans to risk assess healthcare workers or staff and to determine the level of risk and to determine the need for quarantine or the possibility of staying at work with regular, whether that is rapid antigen testing or PCR. That document is in development. The state is working on that document, and we've got an internal document that is also actually in draft, but awaiting confirmation on what the state position is going to be. Clearly, telehealth will be back. Not that it has gone away or it should go away, but that will once again be a modality that is used much more frequently and often to ensure that we limit the number of patients that we have on site to be able to safely distance and care for our patients. The other thing that we are working on, as you know, in 2020, we worked on some alternative models of care during surge. If we had hundreds and thousands of people in hospital, obviously the hospital is going to be in the pandemic plan, and we would reconsider the way of working using students, using volunteers, using other support services to continue to care for our patients. We are in the process of reviewing and reassessing these plans. I think we must admit that we didn't look at these plans when the modeling came out, because at that point in time it was going to be a very contained surge based on Delta and our vaccination status. So clearly that document needs to be brought out and reviewed, which is what we are working on at this point in time. Screening, and there have been some questions about screening, whether we would still be screening patients, whether we would be locking doors, etc. Yes, absolutely. So what is being, what has been in development, and again through the state, is a phased approach to our response, i.e. when we have no community transmission, which is like now, we are in status green, so we probably pre-mask days, we allowed visitors freely to the site, nobody had to wear masks, etc. To when we start getting community transmission, when we go into phase AMBA, where masks are back on, we start screening visitors, we probably start restricting visitors based on the extent of community transmission to status red or status black when we have massive number of cases in the community and we have hundreds and thousands of patients positive. We lock down the site completely and restrict visitors, implement regular testing of patients who need to come to hospital, etc. So we are aligned with that. And again, awaiting some definitive guidance from the Chief Health Officer on the use of rapid antigen testing and how we would use it in the hospital setting and which patients we would rapid antigen test before they arrive to the hospital. Lots of questions about whether we would treat unvaccinated patients any differently. Short answer is no. As a hospital, we cannot refuse treatment to any of our patients, regardless of our vaccination status. Regardless of their vaccination status, what we would do is try and ensure that our staff are protected. And I think I cannot reinforce the importance of appropriate infection control practices and use of PPE to make sure that we are safe, our colleagues are safe, and we don't transmit the infection to our patients. Handing over to Linda for.
So obviously our work environments become very important. So it's talking about the physical environment, but talking about relationships to each other and how we work together. Physical distancing or social distancing, as we're calling it physical distancing, needs to be imperative. Everyone needs to go out now and work out how they can have meal breaks, tea breaks, have their meetings, have their patient handovers in a way that doesn't have large numbers of patients coming together. And in line with that physical distancing comes the cleaning and the cleaning of the work areas and work environments. It's going to be important that all areas are available to be easily cleaned, all shared areas, computers, desktops, office spaces, everything needs to be decluttered and needs to be easily accessible for wiping. So that's going to be part of our infection control guidelines, but we need to get out there now and do that and clear house. As Helen Cadwallader said, we need to look like we're ready for accreditation. So posters off walls, everything clean. It really is up to everyone to go out and do it now. And again, in the infection control policy, and that will update when we come through. Oh, have I? Discharging COVID patients. So obviously patient flow is going to be imperative in the hospital. This over here is going to be our patient flow command centre. So we are going to have people on board trying to manage our beds, understand where they are and where they go. We have a discharge working party that have come together. We're looking at with discharge nurses, with physicians, with the emergency department and with our allied health colleagues, looking at building resources, how we can easily turn patients around in the emergency department to avoid admission, but how we get patients out of the hospital so we can maintain our patient flow. Part of that work is, it's coming together and we're building resources and getting everything ready. There was another point I was going to make and I've totally forgotten, so I do apologise for that. Sorry. So other facilities, we are discussing with our colleagues in North Metro Mental Health and the facilities here. We're looking at transport options and we're looking at ways of getting patients moved in and around the hospital. Long COVID, we have a team that are working together. There's physicians and again allied health and nursing looking to how to manage long COVID. I guess Omicron is only a few weeks old. We're not completely sure of what the pathophysiology of this and whether long COVID is going to be a feature of Omicron, but certainly we have a working party looking to develop ongoing care and post-infection care for this patient group. Communication.
Comms. Really, really important and very aware of the very rapidly changing scenario and that everyone wants information and that there's lots of information coming forth. One of the things that we are going to do is make these staff forums a little bit more regular and as Tracy said, send your queries to the Ask Janet inbox and we'll make sure that they are brought to these forums. At this stage, we intend to have fortnightly meetings, but fortnightly forums, but obviously if there's more information, we'll make it more frequent or upload it via Teams, etc. The COVID Buzz is our weekly newsletter. Not sure if people have seen it, but it's basically a very short, sharp snapshot of what's happening that week and what are the planning preparedness activities in progress and where do you find additional information and who do you contact if you need additional information. So we'll continue with that. Keep an eye out for that. And obviously, you have the North Metro Globals and the Charlie's Osborne Park Globals, which will continue to provide information on a regular basis. I think that's our slogan.
Yeah, so I think what we're looking at is a situation that is changing very rapidly. I think we're all watching the news. There's guidelines, there's state, federal guidelines coming out very rapidly, so things are changing. So we all need to make sure that we're able to be flexible so that we're aware of changes. We need to be ready, so we need to be, everyone in a clinical role needs to be fit checked, need to be PPE trained, we need to be ready, we need to be safe. That's safe looking after ourselves, safe looking after our team, but safe looking after our patients as well. So just bearing in mind, and we all acknowledge that there's a lot of anxiety in the community and certainly everywhere about the rapid growth of Omicron, and it is a very fast changing environment. So you're going to have to make sure that you're reading emails, that you're checking on the COVID hub page, which will have the most up to date and information ready to go. And obviously, I think looking out for each other is going to be very important.
All right, I think that's the end of our presentation there. Fraser, if you're online, is there anything that you'd like to add before I open it up to questions? Questions?
Yeah. Sorry. The plan looks very, very good. Obviously, a lot of work gone into it. My concern, and I'm sure a lot of concerns from most of the staff here, we're not staffing the wards as is on our basic staffing levels, yet we're increasing our beds. We're already, the workforce is already completed. So even before we go into COVID, we're on the back foot. We can't see light at the end of the tunnel from that perspective. And secondly, once COVID does hit, we're going to have furloughed staff as well on top of the already. What's being done about that? Because there doesn't seem to be nurses out there because every hospital is in the same scenario.
Absolutely. Can I get you to make a start?
Yeah, I think we might just. Mandy, are you online?
Sorry, we'll just let Mandy respond.
Okay, so look, thank you for the question. I think I heard most of it. So I'm hearing it's about what are we doing about nursing staff shortages and safe staffing of the ward areas. So we are doing a lot of work in the recruitment space, actually, and in fact, at least two of the divisions are almost fully recruited from a substantive or permanent vacancy perspective. So where we're having the bulk of our deficits, it's within that recruitable vacancy. So against secondments, against maternity leave, and so on and so forth. So that is difficult because it obviously changes quite rapidly. With Ward 7 and the move to Hollywood, obviously we're in the process of recruiting to those ward areas. We have graduates finishing in February, so pretty much all of them, except for one or two, have been given contracts, a lot of those permanent as opposed to fixed term. We have an open recruitment pool for registered nurses. We tried to make our recruitment much more flexible and adaptable, so not using the same rigour that we would normally use when we're recruiting to our organisation. So we've had 263 applications to that pool, of which 196 have been successful. We have appointed about 106 of those, and there's still some work ongoing in reviewing at divisional level those applicants that haven't yet received a job. So we are doing a lot of work. It might not seem like we are. Clearly, there's a lot of internal movement, so particularly to areas like ED and ICU who have substantially increased their profiles. So lots of people obviously taking up the opportunity to get work in those critical care areas. We have, in addition to that, as at the end of December, we turned over a lot of fixed term contracts into permanent. So another 96 nurses were made permanent. We've had, along with all of those offers of recruitment, we have unfortunately had some resignations. As you would be aware, there are currently lots of opportunities within health. So there's a lot of movement across and around the system. We're all fighting for the same group of people, and that's not just in nursing, that's also in allied health and in patient support services particularly. So we certainly appreciate that the wards are under significant pressure, that there are deficits every day. I think that we need to start thinking about what in fact is our or will be our nursing model of care when we're in the middle of COVID, because clearly we're going to be having to work and think differently. We won't have access to the same numbers of registered staff, so we'll be having to use staff a bit differently. We might not be able to staff to a nursing hours per patient day model, but we're looking at other opportunities. So some of this conversation I'm happy to have further tomorrow at the SRN forum. And there are some things on the agenda for next discussion as well.
Thanks, Mandy. Other questions? Yes. Sorry.
Time frame on the guidelines for
Absolutely. So for people on Teams, the question was, do we have a time frame for the guidelines on screening patients attending the hospital for elective procedures? I think just sort of reminding us about the guideline policy that was put in place last year when we had the mini outbreaks of COVID. Those policies and procedures currently stand. So if we were to have an outbreak now, that is what we would be following, those screening questions, that screening procedures, that pre-procedure testing for the high-risk group of patients. As I mentioned, there is work going on at state level with rapid antigen testing, PCR, what tests will be approved by the Chief Health Officer. We're just waiting for those documents to be released so that we can amend our screening policy and guidelines. Thank you. Sorry, question there?
I was just wondering about transport, particularly from emergency to Hollywood for those oncology patients and patients from King Edward to Charlie's, which there will be a much greater number. So will we have an internal transport or something so that that happens a bit more quickly, because waiting for an ambulance could take forever?
Absolutely. So yes, there is working on progress. What I didn't talk about, or what we didn't talk about here, is like we have a Charlie's Osborne Park pandemic structure. We report up to the North Metro Emergency Operations Centre, and as you know, North Metro includes women and newborns and mental health as well. And we've been working closely with both mental health and women and newborns on what that is going to look like. And there have been some simulations to date on transport. Some of them are in progress. Some of those documents on what cohort of patients would be transferred, what would be the trigger for transfer, who would they contact, how would they arrive, etc., are being detailed in a document which will assist with that. So we hope that that will be released within the next couple of weeks and will be available on the intranet. Yes.
I'm wondering, what's the current plan for the COVID testing site here? Is there a plan to remove it from site? Because clearly, looking at what's going on over the east, that's going to be a pending disaster for everybody.
Absolutely agree. So the question was around COVID testing clinics, and if there is a plan to shut down the COVID testing clinics on site, because doing so has created significant challenges for the eastern states. Is that right? Was that the question?
Yes.
Yeah. So short answer is there's a plan for the COVID clinics to be transitioned, the governance of the COVID clinics to be transitioned to Pathwest, and there is work in progress so that we have swabbers who can assist with the swabbing. Clearly the model that is being used in the eastern states, clearly the model that has been used in airports, pop-up clinics, etc. That will help release some of our nurses into the system, and it's not just this clinic that I'm talking about, it's the clinics across WA. So that work is in progress, the governance being transitioned to Pathwest. There was a plan in place which was discussed last year about transitioning the COVID clinics off-site at some point in time once the transition of governance happens. Still under discussion, there is no clear time frame of when or whether that would happen. But clearly, there's that information from the eastern states on how important those clinics have been and the capacity of those clinics. So there are ongoing discussions in that space.
Currently, I'm assuming that if there's a huge surge in influx here, are they all parking in the car park?
Some of them, yes. Very likely, parking in the car park, drop-offs, etc., etc. So yes, really significant impact. Work in progress to transition those clinics off-site, but still available and accessible to the community. Don't have the time frame at this point in time. Sorry. Don't disagree. And absolutely, this is why I mentioned access control and limited access. And obviously, if there is extensive community transmission, it is about protecting the vulnerable patients in our community. Obviously, the logistics of how to check status, etc., are very complex, as you know, David, and as been an experience, especially sort of lock down the site or restrict access to the visitors, but certainly would be considered when there is transmission would be consideration of visitors and restricting visitors and allowing visitors only in required unvaccinated visitors.
Yeah, it's a fair
Absolutely.
point.
Yeah.
It's a fair point, David. I think,
Good point.
Unfortunately, I think the state hasn't made a ruling on it, but take your point and happy to take it back.
I think our people would like us to advocate those strong.
Sure.
I don't know about other departments, but medicine is generally very busy. We're operating at winter level. Most of our units are at 30% over capacity, so you know they're supposed to have, two of our medical units together, sitting at 23, but outliers on many different wards. It's unsustainable, and I just think there's two questions. One is, should we be delaying the opening date? Should we open our borders? Because GenMed generally does have the majority of the admissions in the hospital up to 20%. There's other big disciplines, surgery, but I'm not sure they're having the same pressures that we have. We don't normally have these pressures at this time of year. Second thing is, I'm not sure if colleagues are aware, but an acute medical unit is moving across to Hollywood. And we expect the same sort of services in our complex inpatient, where we will obviously select those that don't have med specs or surgical input, but we can't predict when patients are admitted to hospital in a tertiary setting, that some of them will need these expertise. And it is a ward of Charlie's, and the expectation would be that they will bring the appropriate registrar. And if the patient needs a review, they'll have to go across to Hollywood. And I think that needs to be globally, internally set out, because it would be inappropriate if the patient comes to ED during a time when the pandemic is endemic and is assessed there when it was just a ward of Charlie's. So it should be treated like G71. G71 is the COVID ward. G71 is moving to Hollywood, which is mainly primarily the medical unit.
and it should be having the same service. The patient should have the same service they would otherwise have on any ward.
Absolutely agree with you, Ami, and as you know, we've been working with you offline, including the division on that, and I know that the team have drafted up some comms around it, which we will be working with the heads of departments and the other and the other leads on. Former question. It's not obviously it's not our decision on whether the border is open on the 5th of February or not. There are different. I am aware that there are different views out there. Part of the discussion or the consideration is the timing of the surge if the border opening is delayed, and whether that would coincide with the peak of our winter and peak of our presentation. So obviously it's being discussed at multiple levels, and there's been consideration of a number of things, but we certainly have been feeding back our concerns about the busyness and the fact that we do have a large number of patients at this point in time to the state.
A lot of concerns, even with medical staff, unpredictable. So we wouldn't be able, and it's one of the largest departments really putting it up. That is some of that have really ramping at levels, and we're not really between everyone, having a ward in Hollywood is having.
Agree and understand and acknowledge the concerns, and that's been echoed across the system, not just us, that everyone's been really busy, and whether the timing is right. But as I said, there are a number of things that are being considered in terms of the timing, and ultimately it's the government's decision on when the borders open. We certainly have been feeding up regularly and seriously about that, concerns about our current volumes to be able to manage in a surge. Yes.
I'm aware that throughout COVID, there's been patients have been putting in orders for equipment and finding risks and all the rest of it. From a telehealth, talk about increasing telehealth earlier on. What have we got in mind? Our IT on board, our HSS already ordering it for telehealth equipment. We know that our patient groups now don't all have capability. We're not going to speak to that on the 5th of February. And are we going to be, the task you guys have now involved in telehealth, or is it going to be more of a plan?
Yeah, there certainly has been work over the last several months to create and build that capacity of telehealth when we are in a surge or an outbreak. Unfortunately, it peaked for some time when we had the outbreaks last year or the year before that, and then it sort of went right down to where we were. But certainly there is work happening in the background to actually, to purchase additional equipment, support outpatients in areas that can safely, effectively use telehealth. Really happy for you to feed back to Damon or Linda on any other ideas, suggestions, issues that you may have come across.
Ajit, I think they're struggling to hear the question online.
Oh, sorry, I'll repeat them. This was a question about telehealth and whether there is work being done to increase telehealth capacity, equipment, etc. And the answer is that yes. The short answer is that yes, there is work in progress. But if there are specific issues, concerns that people wanted to feedback, please feedback back through the email address. Yes.
From a nursing point of view, how is the recruitment going for the COVID ward? And if there isn't enough expression of interest to fill it, then how will we start?
Obviously all of the divisions are working together to make sure that we have a plan to be able to staff the COVID ward. So if there isn't an immediate amount of staff that have expressed their interest, then there is a sort of an agreement that staff will be asked to work on the COVID ward.
I think the other thing to add to that is that the work that is happening concurrently and will probably scale up in the next few weeks is that based on what's happening overseas and in the eastern states, very quickly we'll have extensive community transmission, and it's very likely that someone presenting with a broken foot has COVID, and that we have run out of capacity in the 2 wards to look after all COVID patients. So I think the other part of work that is happening is upskilling every area to look after COVID patients and have those to look after patients who are COVID positive and have those skills, training, support, resources available in all clinical areas. Yep.
Doing devices and funds that actually the patient communicate with their family or isolated in a room, patients that are dying.
Yeah, question about communication and if there are devices for patients to communicate with families.
Yeah, so we've got iPads that have been purchased. At the moment, they're just trying to find great solutions that can break through the firewall so we can have option. It may have to be Teams, but at least it can be face-to-face, so there can be conversations with family. That is also going to be something that we as health professionals can use to communicate with patients, so we're not having to necessarily go into the room. But yeah, there is iPads available and we're just working on IT solutions.
Distributed whole hospitals and do all the things be given certain amount of us so we can actually use them?
Yeah, so I'm imagining at this stage it would probably be where the patients are, so they might be there. We don't have one for every bed in the hospital, so probably every ward that might have patients in isolation would have some available, and we would sort of make sure that we can get the IT to support those conversations for family.
Wondering whether redeployment from
So question about whether redeployment from non-clinical roles and upskilling is being considered. Yes, yes, absolutely. So there was some training planning done last year. Again, that is being reviewed, revisited, people being retrained, upskilled, etc. Mandy probably mentioned about up recruiting. There has been strategic up recruiting in, say, some allied health professions to support with some of those, clinical roles. So yes, there is certainly that pace of work happening. Sorry, I'm very mindful. I'll come to you in a second. Mindful that there may be questions on the Teams channel. So if we don't. We've got someone monitoring them, but if we haven't responded to you, we will come back to you with the responses. Yes. Yeah.
So I noticed on the slide that you get
Yeah, so that is obviously we've done a lot of work with the dialysis unit about your risk. You're actually doing a bit of a rapid antigen test for us at the moment. There won't be a specific lead. There's a lot of outpatients that will have outpatient areas that will have patients that are coming in every day. We've talked to the team and they're trying to resource within your department to be able to allocate patients through there, getting some additional resources, some ward clerks and stuff.
Other questions? Yes.
I don't know about testing for staff. I think it's probably as well. Will there be regular testing for staff?
Absolutely, and that's the document that I mentioned, that we are awaiting guidance from the state on how frequently do we test staff, how do we test, what test we use, etc. So yes, there is absolutely a plan to test staff so that we are not quarantining people every time they are in contact with someone who's COVID. When there is extensive community transmission, it could be the random person walking on the street, etc. So absolutely plans in place to rapid antigen test, to test staff on a risk assessed basis.
I think some of the stuff haven't had contact, but they regularly tested.
I think it will be a stratified risk assessed approach, and depending on the extent of community transmission. Obviously, right now, when we had 1 or 2 cases, not every staff would be tested. Testing was available on a voluntary basis for people working in high risk areas. And again, it will be a risk assessed and risk stratified approach, testing staff in high risk areas versus testing everybody. But there will be some clear guidelines around that coming out very soon. Last question probably, because I think we're almost out of time.
Sorry, it's not really a question, it's more of a statement. Can I ask that you have a look at the signage, wayfinding for patients? No one knows what the piazza is.
There's actually somebody walking around today just doing that. So yes, once we would decide on some good wording, then it'll be a couple of days till we get new signage out, but definitely happening as we speak.
The challenge has been for us is that when we went in 2020, when they were developed, we had lockdown, which we don't have at the moment. So the signage that was developed, whilst it's brilliant if we're in lockdown, it's actually not when we're where we are at the moment. So that's weird.
The sign I saw this morning still said lockdown.
I know, but because we haven't, it's because we haven't moved to that. So yeah, we are aware of that, but thank you. Yes.
Thank you very much. Thanks for your time. As I said, we'll make these forums a bit more frequent at this point in time, and more frequent as we start getting cases in the community. In the meantime, if there are questions, please do feel free to forward them on to the Ask Janet inbox or talk to the team. They are available, accessible around all the time. And thank you all for your time. I should probably answer that last question, which is just coming. Is there further information around COVID home monitoring team from the hospital or Department of Health? Yes, absolutely. That's work that is happening at the Department of Health level. The intent is to not have patients in hospital unless they are actually required to be in hospital. So there is a home monitoring program which will be led by the state, and our patient flow command center set up here will be in contact with the state structure program clinicians on people who need to come to hospital, and how do we make that transfer a bit more planned, coordinated, and structured. So yes, work in progress through the health department. Thanks again for your time, and I look forward to the next forum.
Yeah, so just the take-home message is everyone, we need to really clear everything out. We need to be ready. We need to be able to move. But can we make sure that everyone's had some recent PPE training? CNE are able to offer on-the-spot training, come down, offer some more, and N95 mask testing. At this stage, it looks like we need to have our entire workforce ready to meet COVID positive patients. And in order to do that, you need to make sure that you're confident with your PPE. Thank you.
Thank you.
Thank you.